I want to talk to you about patient care. I'll apologize a little bit for those of you who aren't clinical. I'll try to explain the cases I'll discuss in sufficient detail that it will make sense to someone who's not a medico, somebody who's not a physician or nurse. In order to kick it off, though, I need to frame the issue. There's a force that's driving very, very rapid change in healthcare delivery across the United States and around the world, although I'll focus on the US version of it primarily. Best way I know to introduce it, I spent most of my spring of 2009 in Washington, D.C., or flying back and forth. I was asked to testify twice to the Senate Finance Committee. That's where the real power for health reform lives in Washington, is Senate Finance. Once to Ted Kennedy's Health, Education, Labor, and Pensions Committee, once to the money guys on the House side, House Ways and Means. We had two issues on the table. One was 46 million Americans without health insurance. It just seems wrong that the richest economy in the world would have that fact hold true. Roughly 15 to 17% of the population without access to health care through insurance. The second, in some ways, was more profound. Healthcare cost increases that were bankrupting the country. Now that's where I spent most of my time in testimony. Well, not just with the committees. The real work of Washington happens at a senior staff level. That's where all the arguments are made. That's where the issues are debated. That's where the legislation gets drafted, and spent literally weeks of time at that level. Got a little bit, not nearly as much as I would hope, frankly. And now we're confronting it. What we really got in the ACA, the Patient Protection and Affordable Care Act, PPACA, was insurance reform, with a very small tip of the hat toward those cost controls, but it's now becoming more prominent in the news media, isn't it? Much more prominent. This idea of, can we afford this health care that we expanded for others to have? That's where this comes into play. Now, we often talk in terms of the federal deficit. These data are from 2009, the same I used when I testified to those committees. It's a little worse since then. The national debt's now approaching $17 trillion. It's on this slide, actually. The deficit in 2009 is right to that orange line. Turns out there's some much bigger things, though, that loom ahead. The truth is that the federal government's income falls far short of its committed outgo. We call it the fiscal gap. And the gap is far more important than the deficit in the long haul. It shows how fast the deficit will rise in the long haul. So, for example, the reason you younger people in the room really shouldn't count on Social Security, despite that program consuming roughly 13% of all wages and salaries in the country, 6.5% on your pay stub, 6.5% matching funds from your employer, roughly, that program is $7.7 trillion short of meeting its obligations for people alive in 2009 as a net present value. This doesn't include people born after 2009. Well, wait a minute. That's roughly the same size as Medicare Part D. That's that drug benefit that the Republicans passed back in '98 using similar legislative tactics, by the way, in all fairness. That program, $7.2 trillion short. Part B is the big guy. It's payments to physicians for professional services, inpatient or outpatient. Oh yeah, $17.2 trillion shortfall for people alive in 2009 for Medicare Part B. Part A is the hospital trust fund, a mere $13.8 trillion. Now, if you total it all up on this slide, it comes to $60 trillion, roughly. Since then, we've had a better commentator. This was from a fellow named Walker, who headed the government accounting office, probably the most trusted financial analyst in Washington. Well, he retired last year. A guy named Foster, the actuary for CMS for the Medicare program. Dr. Foster said that the real number is closer to 120 trillion. And if you do it in perpetuity, as you should with the net present value, the number is 211 trillion. 211 trillion, boy, that's a big number. How do you make sense out of that? Well, the best way I know, the present value of the United States of America, all public and private, physical and intellectual property, your homes, your cars, the clothes you're wearing, this building, my laser pointer, my glass of Diet Coke, all of it. About 75 trillion. Just to put it in perspective. What I'm saying is technically looking ahead, the government of the United States is bankrupt. I mean, not just politically and morally, but financially. Is a way to say that. And nobody really debates the numbers. Did you notice that 2/3 of the problem is the National Medicare program? The size of the bubbles are accurate. 2/3 of the problem is healthcare in this country. And that's the force that's driving the debate, right there. That's the reason it's not going to go away in the foreseeable future. Oh, it's led to some particular behaviors. When we were working on the ACA, the president asked that we limit additional federal deficit spending to $1 trillion through 2020. We did that through 3 primary mechanisms. The first is we used 10 years of income against 6 years of expenditures. The insurance expansion really happens in this year. 10 years of income, 6 years of expenditures. It's a little bit of classic Washington smoke and mirrors with financials. Let's just say in 2020, when it goes on year-over-year financing, there's this hockey stick effect in the deficit spending associated with it. That was thing number one we did. Number two, fairly massive tax increases on a broad scale. So for example, you can expect your insurance prices to go up by 3%. That's the tax on existing insurance to pay for some of the new insurance. And that's just one of many different tax sources. The third, though, was more interesting in a way. We assumed that we could pull about $600 billion out of healthcare itself by reducing government payments for healthcare. This again comes from the Office of the Actuary at CMS. Yeah, 2012 right here. This is what happens to payments to physicians for their services under the law in order to fund healthcare. So this is private health insurance. This is a Medicaid program. This is Medicare for people over 65 years of age. It just assumes that it drops dramatically. Well, by 2020, it's supposed to be about 50% of the actual payment you'd receive for commercial insurance, well below the actual cost of delivering the care. Another version of the same, this is the impact on hospitals. Yeah, currently a little bump before. We're right about here today. But the idea is that it continues to drop. In 2020, 40% below. You see? We just assumed that somehow that we could deliver the same services. What would happen if we did that? What do you suppose would happen if we cut payments to physicians and hospitals to this degree? Yeah, what it means is you'd have insurance, you'd have Medicare if you're over 65. In this specific example, you just wouldn't have a physician. You just wouldn't have a hospital who's willing to admit you as a patient and deliver the care that you need. They couldn't. There's a financial reality behind this. If they did, they wouldn't last. They would fail. They would disappear. The American Hospital Association estimated that if these played through, that by 2020, at least 1/5 of all hospitals in the United States would fail and go out of business because they couldn't make salary to pay their staff. They couldn't generate enough income to buy supplies, you see. Nobody really believes they're real, these projections. We believe there's a political reality behind it, that it will demand more payments, but it will show up as dramatic increases in federal deficit spending and continuing dramatic pressures on funding for health care. Well, just one example. This comes from a system called Vera. They were nice enough to lay it out as a table. These are current programs for Medicare cutting payments to hospitals as part of the effort I just described. These are real. You may have read in the newspaper about readmit rates for hospitals. This year, about 80% of hospitals in the country will lose Medicare payment amounts because of readmit rates. Well, on readmits will be 3% of your funding. If you total them all up, about 10%. And since the slide was built, they've actually added some more. So it's running about 10 to 12% of payment for Medicare patients pulled back is the idea. See the idea? The takeaway from this, it's very, very clear. Financial pressures on healthcare delivery are going to be dramatic. If you think it's been bad so far, which people within the industry believe, they ain't seen nothing yet. That's what these numbers are predicting. And it's just going to be plain nasty in terms of funding for care delivery, you see. Now, it turns out there are two main ways you can address this. In the past, we worked under what was called a fee-for-service payment system. You had to make an operating margin. If a company doesn't have about a 3% operating margin, you will die. That's income over expenses. That operating margin is for growth, but it's also to replace capital, to replace buildings as they age out, equipment as it ages out, stuff like this, right? And if you drop below about 3% in healthcare, nobody has an exact number, but you'll gradually die and pass from existence. The further you are below, the faster you die. The federal law for not-for-profit healthcare organization allows you 8% of what's called retained earnings for that purpose under federal law, you see. Well, in the past, the way we solved this problem, you had to have revenues higher than expenses. People focused almost exclusively on revenues. Develop that new technology, that new treatment, and get it out there to make high margins, you see. Build that new heart hospital. Attract that new superstar physician to get more referrals into your facility. And what we call that is top-line revenue enhancement. All right? Stand that in contrast to a shift to bottom-line cost control, where your revenues are capped or maybe even shrinking, and then your only hope to maintain an operating margin to survive is to drop cost out of your system. Fair enough? An illustration of the first. 3 years ago now, Mayo Clinic released a strategic report. Well, a few years before that, a guy named John Noseworthy stepped in as the new CEO of Mayo, a physician over in Rochester, Minnesota. And he launched this committee to do a strategic analysis for Mayo's future. And this was the form of their report in a summary way. They expected, under the face of these kinds of financial pressures, that over the next 10 years, primary care would shift almost entirely to what's called capitated payment, where physician groups are paid a per member per month capitated payment. They can deliver all the services they want to underneath that. It just won't change what they're paid in any way. All right? They thought that typical hospital services and specialty care would move to what's called bundled payment. That's how you handle capitation at a specialty level. So you define a particular service, and here's your flat rate for this service. Everything's bundled into it: the physician fees, the imaging, the medications, the testing, any complications or readmissions that happen are bundled into it. And their read on these two is it means very low margins, right? Cost-based competition with very low margins. Mayo thought that about 2 to 3% of the care would still fall into this peak up here. They called it complex care, diagnostically difficult, executionally challenging, kind of bleeding edge care up at the tip. 2 to 3% where they would still have fee-for-service payment with high operating margins. And in fact, what Dr. Noseworthy proposed was a strategy to focus Mayo's care delivery around that tip right up here. He called it a destination medical center. A destination medical center where people would travel in to receive care at this very high-end specialty care, you see. Oh, the Mayo report, this is where it got interesting, estimated that the United States of America has a population of sufficient size to support 5 destination medical centers for the country. All right, 5. Oh, did you notice that that's the market that most academic medical centers target? Is their niche market? 141 registered academic medical centers see their business is falling mostly right there. And that's what made the Mayo report so interesting. It was a secondary finding. Mayo was saying about 5, including immigration from people coming outside the United States to receive care. And there's a big difference between 5 and 141. You see? I mean, even if they're off by an order of magnitude, there's still a big difference between 50 and 141. And the prediction that comes out of this is as we see financial pressures mount in care delivery, the people who are going to be right under the crosshairs, more than any other group, will be academic medical centers. So I've been checking with my colleagues around the country. And so far, I've found no naysayers of that. And in fact, we're seeing it start to happen, of intense financial pressures, especially focused on traditional academic medicine along the way. So I do say this to a group like this to be just a little bit alarmist. I trust your leadership is looking at this closely, very closely, thinking about it. Well, what does it mean when you can't get any patients into your clinical services? What would it mean to you as a university? What would it mean to you as, frankly, a business operation? Because that's what's very likely to happen. That's what these numbers at least imply. Now, there's another way of looking at it. Yeah, remember that shift to bottom line cost? And there's some reasoning behind it. I'm a bit of an anachronism. I think I'm one of the few people still alive who actually learned quality theory from W. Edwards Deming. Dr. Deming, the father of quality improvement theory, long since dead. I knew him toward the end of his career, at the start of mine. Well, a few years ago, a colleague and I, Dr. Lucy Savitz, got a little grant from the Agency for Healthcare Research and Quality, AHRQ. Our purpose was to take Deming's idea of waste, quality-related waste, and morph those models from really a manufacturing environment into a care delivery environment. We ended up with a 6-part model, which of course I really like. I think it's just brilliant. But then I developed it, so of course I would. When we applied it, we were able to generate national level estimates for only 2 of our 6 categories in the model, just 2. Admittedly, they were the biggest. But the other 4 are definitely non-trivial. On the basis of those 2 alone, we estimated that over 50% of all resources expended today on healthcare delivery is technically waste. Non-value adding from a patient's perspective. I mean, this year I'm talking 50% of a $2.8 trillion spend for the United States. Do you know of any other industry that has a $1.4 trillion market capitalization rate? 1.4 trillion. Now here's the point. Somebody's going to figure this out. They're going to figure out how to start to pull that waste out and monetize it, turn it into advantage. When they do, they're going to create a new world, and it's going to be very, very richly rewarded as they create that value for, well, people not just living in the United States, but around the free world. That's the idea. I served on the IOM committee where we said 35% waste. You probably saw that published number. Frankly, our models weren't as strong. It wasn't worth arguing 35%, 50%, who cares? When it gets that high, it just wasn't worth fighting about, and the report was actually focused on something else mainly. It's funny how the news media grab a piece like that and go to town with it. And it's a really good report, just in passing. But that's the idea. Now, in that context, I need to show you a method. It's a systems method. We stumbled into it, frankly, by accident back in 1991. The person who led the work was a fellow named Alan Morris. It was at then Intermountain Healthcare's flagship hospital in Salt Lake City, LDS Hospital. We've since moved to a new facility called Intermountain Medical Center, a few miles away. The context was a big randomized controlled trial of a new high-tech treatment for something called acute respiratory distress syndrome. It's a disease of the lungs. For reasons we don't understand, some people will leak tissue fluid out of their cells in the lungs into the air spaces. And as the air spaces fill with fluid, no more gas exchange, no more carbon dioxide out, oxygen in, and it kills people. It's a deadly, deadly disease. Now, the way we traditionally manage this is you take somebody suffering from ARDS, stick them in an ICU, intubate them, put them on a mechanical ventilator, and try to drive enough oxygen into their blood through that portion of their lung that's not fluid compromised, using something called high index expiratory pressures and high oxygen concentrations to keep them alive, all right? Well, in this context, a group of Italian researchers had come up with a really cool high-tech solution. It was an artificial lung. Fundamentally, what you did was roll a heart-lung machine out of surgery that we used for bypass surgery down to the ICU, plugged it into a patient's femoral artery, circulated their blood out of their body. In the pump, in this roller pump, you ran it through a CO2 scrubber, then a membrane oxygenator, outflow into the femoral vein, and the idea was you could slow or stop respiration, let the lungs stop and recover. And we were thinking that this might improve survival. in this class of patients. So we're putting together the trial when we bump into a real problem. It's one of the first time we'd looked carefully. You see, starting in 1986, we were one of the first groups to start to study variation in practice at an individual patient level. And what we'd found was massive variation, not just across physicians, among our nurses, physical therapists. It's endemic in all of healthcare, not just in the United States, but around the world. Huge variation. Now this is death to a trial. If you don't deliver the care in the arms of your trial in a consistent fashion, you can't tell if differences in patient outcomes causally relate back to the treatment you used, or if it's, really a spurious result associated with the major confounder you introduced through inconsistent treatment. That's why we use protocols in the arms of trials. It's just a key trial design principle, right? Nobody had looked at it before, so we encountered this thing, and what we knew is that we needed a protocol for ventilator management in the ICU for the control arm of our trial. Well, we set out to build it, and there our research again turned out to be a real impediment, a millstone, really, whole series of problems. The trouble is if you go looking for evidence for best practice among competing treatment alternatives at a level 3 standard, that's expert consensus opinion, using formal methods in a published form, you can find, on average, you can find evidence for best practice only about 15 to 25% of the time. 75 to 85% of the time, physicians and nurses can hold legitimate differences of opinion about what's best because there is no evidence, even with that kind of a soft evidentiary standard. Now, it's better in some areas. Pediatric oncology, it's probably up around 40 to 50%. On the other hand, general pediatrics is very close to zero. General surgery, where I trained, very close to zero. See the problem? No evidence. There's a bigger problem. It's how evidence increases rapidly. David Eddy, the father of evidence-based medicine, says it nicely. He says the complexity of modern medicine exceeds the capacity of the unaided expert mind. And a truer thing was never said. And strong evidence backing up that statement, by the way. A third problem. If you rely on expert consensus, it's unreliable. For common questions, if you ask a group of respected authorities using formal methods, if you look at an individual expert level, you get basically full range. I mean, for something like a failure rate of breast implants is one that I recall. One expert surgeon chosen by his professional society said 0.2% at 5 years. 0.2%, 0.2% failure rate. Another surgeon said 100%. This is what we call full range, guys. Pretty much physically impossible to have a wider divergence of opinion. And the real problem is across 58 expert surgeons called together by their professional society, no discernible pattern of response. Eddy went back and demonstrated this broadly across every subspecialty of medicine. And what it does is completely destroy any faith you may have ever had in expert consensus opinion as a means for identifying best care. That's what it does for you. All right? And it kind of leaves you out there twisting in the wind, frankly. We also have a strong body of evidence that shows that guidelines don't guide practice. You prepare a guideline, you publish it, people read the article, you take them to grand rounds. If you ask them, they'll say it was valuable. If you ask them, they'll say they changed. The wheels come off when you measure whether they changed. And they don't when you actually measure it. And the last one's the biggest. I'm going to come back to it in a moment. I have hard evidence, with some very rare exceptions, you cannot write a guideline that perfectly fits any patient. The patients who come to us for care are too different from one another. You can see it looking around the room. We all look different, don't we? I trained in surgery. If I were in your peritoneum, I know that there would always be small anatomic differences. Well, usually small, sometimes rather dramatic. And I know that I'm going to have to adjust to you as an individual. It's the best way I know how to illustrate an empiric fact. But that's how it plays out in the evidence. I can't write a protocol that perfectly fits any patient. Well, that's where Dr. Morris came in. We just encountered a book by a guy named Womack called The Machine That Changed the World, published in 1990. It described Toyota automobile manufacturing something called lean. And one of the three main legs of lean is something called mass customization. The idea that you design a standard process that can adjust to the needs of individual patients. Now, let me just say in passing, that idea is not new to medicine. I was actually trained in it as a surgery resident 20 years before this, in honest truth. You see, It's not new to medicine, we just hadn't called it forth. Well, yeah, what did it look like? So here's the key to the method. Imagine that I pick a high priority clinical process, right? I pull together a team of people who have fundamental knowledge who actually do it routinely, and we hammer out that evidence-based best practice protocol despite its manifold limitations. Do it anyway. Of course it's not going to be perfect. Just try to kind of come into the ballpark with it, all right? Next step, this is one of the harder ones. Blend it into clinical workflow so that it doesn't rely on human memory. Engineer it in to standing order sets and what we call clinical flow sheets, action lists, patient worksheets. We have a whole series of tools we use. So doctor, if you just let it happen, what you're going to get is the evidence-based best care. Don't mess with it, you'll get the evidence-based best care. Without a thought, right? It means I can manage it. I can manage to a standard. Oh, our jargon for this is standard work. So define the standard work. Well, in addition to the clinical workflow, I have to build in a data system. The data system has two primary purposes. The first is to track protocol variations. This has to do with mass customization that's coming up next. Anytime somebody varies from protocol, changes one of those orders in that standing order set, makes a logic jump different from what the diagnostic workup recommends, right? I need to be able to flag it, the fact that it happened. Then side by side with it, I need a data system. Well, here's the key to this one. It has to be based upon the actual protocol workflow. You got to get the data system right, the way that the work happens. But you track the jargon, intermediate and final patient outcomes, not just clinical outcomes, but financial outcomes, side by side, all right? Yeah, step number 5 is my favorite. Here's how I say it to the physicians and nurses inside Intermountain. We have 22 hospitals, about 200 clinics, about 4,000 docs, 34,000 employees, mostly nurses. A fairly big system. 50-60% of all care delivery in our region of the United States, across 3 states. Ladies and gentlemen, it's not just that we allow or even that we encourage, we demand that you modify our shared baseline protocols on the basis of individual patient needs. I have hard data demonstrating that they never perfectly fit any patient, with rare exception. And doctor, that's why we have you. Nurse, that's your job. You need to decide what varies and how it varies. But you stand between your patient and the protocol, getting it right. It means they're the opposite of cookbook medicine in a very real sense, the exact opposite. You know what's the craziest thing? In order to vary in a meaningful way, you have to standardize. That's the crazy thing. Standardization is the key to effective variation. It's a principle that you see in trial design, just in passing. It's the fundamental principle behind effective clinical research. And all that we did was kind of pull it over into routine practice. You see the idea? Now, of course, if you vary, we don't stop there. We're going to feed those data back in what's called a lean learning loop. And you build organizational structure to use the data routinely to say, well, when did people vary? You also pull in new science as it develops, right? You'll get good ideas off your front line. Any of our protocols, though, tend to change every month. The teams meet every month, and every time they meet, they'll tweak them. Usually fairly small. Occasionally, if there's a breakthrough in science, a fairly dramatic shift. And we use them as a context to conduct clinical research. More on that in a minute. See the idea? This shows with ARDS what happened when we did this, and this has been true for about the 60 of them that we have running. Initially, you get fairly low compliance rates, and then as you do the feedback loop, you nearly always see this fairly dramatic rate of change. Oh, this was on ARDS. That protocol had about 840 steps in it. It was admittedly complex. Dr. Morris is nothing if not thorough. But in the first 4 months of its use, more than 125 changes to our best shot evidence-based best practice guideline. And that's been true for every one we've ever done. That abstract document tends to change wholesale when it hits reality. This is a form of validation. How do you validate the protocols you create to make sure they actually work? So what you're seeing is a validation loop. You'll notice that, yeah, no 100% compliance out there. This is used now by 16 academic centers who participate together in research on this topic, ARDSNet. More than 100 other big ICUs use the same protocol. We have thousands of patients through this thing now. To my knowledge, yet to have a single patient where we've had 100% compliance. You can't write a protocol that perfectly fits any patient. On the other hand, it does produce some results. Yeah. Survival for the most seriously ill patients, the actual focus of the study, improved from 9.5% to 44%. A dramatic improvement in patient survival. First time since ARDS was defined as a syndrome in the 1960s that anybody had shown an improvement in clinical outcome. Since well validated and sustained across ARDSnet. Oh yeah, costs fell by about 25%. Now I expected that. That comes straight out of Deming's theory. You were eliminating particular forms of waste. And it's a very consistent finding to see costs drop. Higher quality almost always costs less. There is some circumstances where it costs more, but in most, the best way to get cost out of a system is higher quality of care. And the other fascinating thing, this is where we carefully measured it. Now this is an ICU setting, non-procedural, so this is thinking physicians, internists. About a 50% drop in physician time. A better way to say that, a dramatic increase in physician productivity associated with this. As a direct result of using standard work as a foundation for appropriate variation. Another way I sometimes say it, and this is really true, we're going to track your use of the protocol. If you vary from it in ways that are different from your colleagues, you're behaving differently from your colleagues, I prefer to have enough sample to do it statistically. But if I don't, I can do it one case at a time. It's nice and fractal that way. If you're different from your colleagues, either you have something to teach us or we have something to teach you. It's what's called a learning system, the learning healthcare system at its core. You'd be surprised how often it's number one. Somebody will have a new idea that when you get data flowing behind it, works out, and then you quickly adopt it and move on if you see the idea behind that. Can I show you just a couple of other examples? The number one cause of death in any U.S. hospital today is something called sepsis, a body-wide infection. A little bit more than half of those will enter your hospital through the emergency department in a typical hospital. That's what I would expect if I looked here in Michigan, for example. It's a deadly, deadly disease. Nationwide, between about 20 and 50% of those patients die. Well, a few years ago, head of our ICU system, Dr. Terry Clemmer, one of the fathers of intensive medicine, one of our emergency room docs, Dr. Todd Allen, put together a shared baseline protocol for the very aggressive detection and treatment of sepsis. It shows protocol compliance. The blue line is in the ED, the red line is in the ICU. It's got that feedback loop running. It's not quite as fast as happened with ARDS. This is across 3 years. But it goes from 30% up to about 90% where it is today. We were pretty good when we started. We had about a 20% mortality rate in this class of patients, which is as good as you'd find in the country. Yeah, it's been now 3 years since it's gone over 9%. Now that's about 125 lives per year, as it turns out. About 125 people who didn't die who would have before. Well, wait a minute. I've got more than 100 of these. I can document more than 1,000 lives per year in the Intermountain system of people who would have died who don't. And as you probably understand, mortality is the tip of the iceberg. The effects are far more dramatic when you look at function restored, pain averted, the other key goals of care delivery. So first takeaway, and I really want you to hear and remember this one. In this line of work, number one, we count our successes in lives, literally. This is more dramatic impact than I've seen with any other area of clinical investigation, frankly. By systematically measuring and applying research tools to routine care delivery performance, and then beginning to manage that performance on behalf of our patients. We count our successes in lives. The second thing, though, this shows the actual costs associated with sepsis. I would call your attention to that line right there. This is net operating income. It's that margin you have to maintain. Yeah, it's contributed about $720,000 per year to our operating margin. It's cheaper. It's cheaper to treat those patients if you catch them fast than if you wait until they're in extremis and failing. It's less money. I can document more than $400 million per year taken out of the cost of operation of Intermountain. That's not charges, real costs from improvement efforts. Lesson number two, Nearly always better care is cheaper care. What I'm talking about is that waste piece, right? What I'm talking about is bottom line cost control as a survival mechanism. I don't think I put the slides in, but a funny thing, a few years ago, our CFO, Chief Financial Officer, set a goal for us. He said, I want to limit rate increases for this system, our burden on the community, to a maximum 1% above consumer price index inflation. He called it CPI plus 1. I wish he would have said GDP minus 2. What that means is that healthcare is shrinking as a proportion of our GDP in cost to the community. We'd set a goal to achieve that by December 31, 2016. I thought we had it last December. We were a hair's breadth off. By this point we have. It's associated with rather dramatic drops in volumes in our hospitals. Our volumes are dropping. It's three things. The Great Recession had an impact, but even bigger, beyond that, believe it or not, it's high deductible health plans where patients have a little bit of skin in the game in terms of what they consume. Inappropriate categories, we need to say that. But lastly, it's deploying these things. So we just went through a financial review. We got through 6 of our 20 roughly projects from last year, about $40 million. For example, appropriateness indications for cardiac catheterization, stenting, and electrophysiology, pacemakers and defibrillator implantation. But they showed about a 1/3 drop in how often we do those. Of course, if I were fee for service, that's cutting my own throat, isn't it? Well, if I look at it as a patient though, how do I feel about doing procedures that turn out to be clinically inappropriate, not necessary? Yeah, that was $17 million drop from cardiovascular, getting their indications down tight and deploying them as a shared baseline. And there are lots more of them. See the idea? Here's the craziest thing. Last year we probably had the best financial year we've had in 10 years. And the reason is with waste elimination, our costs of operations have dropped even more as we right-size our health care to the needs of the communities we serve. See that idea? Yeah. Waste elimination. Now, last trick, another little clinical study. Turns out the biggest single process that we operate inside Intermountain Healthcare is pregnancy, labor, and delivery. We deliver about 35,000 babies a year as a system. Well, sometimes when you deliver a child, they come a little early. 40 weeks is a full-term birth. 37 weeks is close enough. It's kids who are between 33 and 37 weeks. So they're borderline premature. Below 33, you're truly premature. The last organ system that develops in a developing newborn is the lungs. And for borderline premature kids, they sometimes develop something called respiratory distress syndrome, or DS. Their lungs collapse at the end of each breath. It lacks structural integrity. They're blue babies, and they will die. Of course, we've had a technology to treat that for these many years. What you do is intubate them, stick them on a mechanical ventilator in the newborn ICU. All right? And they tend to do really well. You just need to give them a couple of weeks for their lungs to mature. But they'll spend 2-3 weeks in the NICU. Yeah, their mothers tend to cry a lot when they see what we do to their babies. But it beats dying. Kind of tough love, I guess. But there you go. Well, some people at one of our little community hospitals, American Fork Hospital, came up with a bright idea, working with our neonatologists at one of our big tertiaries, a guy named Steve Minton. He said, you know, these kids are almost mature. Do we really need to intubate them? It turns out there's an alternative technology. It's called nasal continuous positive airway pressure, NCPAP is the name of the thing. Yeah, nasal CPAP. You've seen those sleep apnea machines that plug into your nose and blow positive pressure up through your nasopharynx into your lungs? Same thing. It's been used for decades in neonates. It's safe. And they said, maybe these kids that do okay just with NCPAP don't need intubation. NCPAP, a little oxygen, something called surfactant. And we ran a trial. And sure enough, in the trial, it worked. The proportion of kids transported for intubation fell from 78% of these kids to 18%. So in case you missed it, this is a dramatically better clinical outcome. All right. Well, he came back and asked me to run the financials, and by this point I knew about the financials. What I'm measuring here are operating margins. our actual charges to insurance companies dropped dramatically. So in this cohort of about 110 kids per year in the context of the trial, in the kids where we did this, it dropped the charges to insurers by about $870,000. Then I went back to see what happened to the hospital. All right? American Fork, the little community hospital, they actually saw a real bump in net operating income. It's because the kids tended to stay in their nursery for 2 or 3 weeks on NCPAP, right? They claim it's a level 1 NICU. It looks like a nursery to me. But because they delivered more services, they made a little bit of money. We pay for the nurses for transport. We use a third-party ambulance company to actually move these children 15 miles down the road to the tertiary hospital. Well, back here, if a nurse was on call for transport, they got used and we billed for services and made some money. After the fact, they're on call, which means they get call differential. But we didn't use them. And so we lost $50,000. Oh, the hit was down at Utah Valley, our big tertiary with that NICU. We dramatically reduced NICU census through this. Their operating margin had been about $960,000, it dropped to $210,000. They took a $750,000 margin hit. Well, if you summarized it for Intermountain, we lost $330,000 in operating margin. That's the difference between our actual payments versus our cost of operation. We took a $330,000 hit, while the insurers were $870,000 to the good. Now, let me just ask, what's wrong with that picture? Did the insurers have anything to do with the improvement in care at all? No. Didn't contribute a single idea. Weren't there, not a single word. They get this huge windfall savings while the people who improved the care take a major financial hit. This is just a good illustration of what happens on a much broader scale. Short version. Turns out that the current fee-for-service payment mechanisms actively incent overutilization. I'm paid more to do more. And it shows up in our system as unnecessary, inappropriate care, frankly. Our best national estimates of inappropriate care say that about 15 to 20% of all hospitalized patients are there inappropriately, just in passing, where the risk of the treatment outweighs any potential benefit at great cost. It gets worse. I'm actually paid more when I have major complications, preventable complications, patient safety. I mean, think about that to the extent that a payment system reflects social values, which it should. I'm being incented to harm people through the payment system. I have to overcome those financial incentives to do what's right for my patient. Should be no question, but they clearly have an impact. The other real bad one, it takes money to run the improvement work. It takes money to set up the systems. And every time I do this successfully, my money to do the next project just disappeared, right? By the way, what we did as Intermountain, after it worked at American Fork, we deployed it across our entire system and turned a little $330,000 margin hit into about a $10 million margin hit, is what we did. And, well, wait a minute. That's not the only time we've done it. See? Yeah, when I started, I was talking about what Mayo saw coming in terms of payment. We call it sometimes pay for value or fee for value, but it's where you shift the financials so that really they fall on to the care delivery teams and the patients who use them, where the patients actually are part of the decision-making process. Sometimes they're not. This comes from the ACO legislation that came out of CMS and CMMI. And what it really is a series of approaches to payment that step you through a small step at a time, ramping up into a full capitated system. But that's what we see coming next, is full capitation. I got to tell you, though, for Intermountain, we're actively driving in that direction. Oh, best guess. It's exactly the opposite of the financial model you use in this health system at your university. Exactly the opposite. You see? You're paid to do more even if it's not beneficial. You're paid to harm your patients. You're financially punished if you improve care and reduce waste. Can you see why we as a system made the decision to shift over to that other model as quickly as we could? Yeah, it changes your model. In the past, it's all about top-line revenue enhancement, and quality was really regulatory compliance, looking good enough to the regulators that they didn't come shut you down. reputation in the newspapers. The future, turns out that process management and quality becomes your absolute core business strategy. The way we say it in Intermountain, the best medical result at the lowest necessary cost. And I've shown you the main method we do it. We build shared baseline protocols, we integrate data systems into them, and we deploy them out broadly. Yeah, process management is the key. And that's something that any engineer in this room knows about. From an industrial engineering standpoint, higher quality drives lower cost most of the time. Under aligned financials, this fee for value payment, the savings drop to the care group's bottom line. That's why our financials look better than they ever have. You see? Now, interestingly, more than half of the savings show up as unused capacity in your system. It creates capacity, really. But that's going to be counterbalanced, we think, by people aging into their chronic disease years as the aging U.S. population, the baby boom coming into that phase. Utah, at least, our population is growing plus new technology. But it means I can use my same physical plant to deliver care to a larger population with greater need. I don't have to build out more fixed costs, more buildings. It's the basic idea. Now, just one last thought as I wrap this up. Imagine that I make the substantial investments in data systems, in clinical organizational structure to build this out. Identify high priority clinical processes. We call them clinical development teams, one for each process. And those are the physicians and nurses who review the variation data, right? Keep the protocol up to date. They also keep track of the new science. It's a way of deploying knowledge within a care delivery system, really. I have to build out those data systems. So we currently have one of the finer analytic systems in the world, I think. A series, we call them data marts, or registries, patient registries, longitudinal patient registries. Got about 60 of them that represent about 80% of our care running. 2 petabytes of storage on that system. And as you know, a petabyte is 1,000 terabytes, is 1,000 gigabytes, is 1,000 megabytes. So it's a fair bit of storage. And about 60% of it goes for the clinical need. Well, imagine that I make that fairly substantial investment for the purposes of care delivery performance. But once I have it, I then turn around and use it. Well, what I'll say is learn from every patient. Yeah. We actually break out levels of research. So traditional academic research that you do here would be level 2. We identify a level 1. The basic rule is it has to have a relatively rapid impact on our actual care delivery performance. We call it level 1 research. It's where I can justify investing patient care dollars in research. You see? What you're doing is you're taking the tools of the academy, tools of good health services research, and swinging them over into care delivery operations. Trained researchers usually. We embed them in our clinical development teams. And you measure your success by how much you change patient outcomes in actual performance. See the idea? Well, last year, my best clinical development team, NICU team, Bob Christensen, 23 peer-reviewed papers out of 1 development team. Last year, 2 of them were seminal breakthroughs in care delivery. Don LePay, who heads up cardiovascular, he hates it when I give women's and newborn top billing. 64 peer-reviewed articles, 67 abstracts, 15 other elements of academic production. Oh, you want to hear the funny thing? Technically, we're a community-based care delivery system. I suspect that we're producing more academic output than your equivalent departments in your university. Substantially more. At the ACC meetings, the American College of Cardiology meetings a couple of weeks ago, we presented 14 papers out of this bunch, looking ahead for next year. The closest academic institution presented 2. Can you see how it happens, though? It's because you've given those researchers a framework to learn from every patient. It's the data systems, it's the organizational structure, and I've got a prediction. That's where the care is going to go. That's where the clinical research is going to go. Embedded in actual care delivery operations as you line these things up. I have a series of other clinical development teams. They're not as prolific as these 2. Oh, and by the way, this is 3 teams. And when you divide 64 by 3, Bob Christensen wins by a hair's breadth, just in passing. Did you see the idea? Well, let me just close by saying it one other way. This is the theme for my little Institute for Healthcare Delivery Research. Better has no limit. I think you've just started to see the impact of these kinds of methods. I think it's the future of the healing professions and healthcare delivery. I think it's a glorious time to be in healthcare. We have not yet begun to understand how good we can be. I think the rate of knowledge generation is going to accelerate. I think we're going to link it much more tightly to routine care delivery operations. And it's going to be fun, to say the least. That's our future. It's been a privilege to be part of it, frankly. We're giving you young people an even better future in terms of what you can do to make this world a better place for those who walk its paths. Again, we haven't begun to understand how good we can be for the people who seek our help in their hour of greatest need. And with that, let me say thanks for your time and attention. Any comments or questions?